Welcome to this mental health question event. As you might know, these are 40 events in UCL, and they are organised by the UCL Psychiatry, Mental Health, Andres, and Ben, and the Lancet Psychiatry. And so we're going to use that you were here on late afternoon in July, as recently here. Just so you know, these are really events to connect the general public to what's happening in policy research in general. So as much as there's a panel here who really welcome your questions, this event is just as much about what you have to say as what we have to say. I'm just going to have a few housekeeping issues before starting. We don't expect any fire alarm, so if it goes off, let's just go out from our fire exits. Toilets are outside the door on the right. We have free Wi-Fi if you need to connect. The name of the network is UCL Guest and the password is MHQT99. If you want to tweet about the event, please use the hashtag MHQT. And then after this, we'll have some drinks and meals just outside here. We're going to head back to there. So if you want to stick around, ask you questions, have a chat, you're more than welcome to join us. So without further ado, I'm going to introduce the chair of this panel, Dasha Nichols. Dasha is a reader in child psychiatry in Imperial College London, and she was previously for over 20 years at the Gosh Performance Street Hospital as clinical lead for the National Eating Disorder team. She's an honorary consultant child and adolescent psychiatrist specializing in feeding eating disorders in children and young people. She's board chair of the faculty of eating disorder at the Royal College of Psychiatry and president of the Academy of Eating Disorders. Many achievements. Let's just say that's enough. Well, we can ask for a better chair for this event, so I'm going to pass it on to Dasha.
I have my own microphone. Thank you. Thank you and welcome. I get to be David Dimbleby, Fiona Bruce, and myself for this event on eating disorders, which I'm delighted that I think there have been a number of these sorts of events, but to have one on eating disorders really does bring together a fantastic opportunity to hear different perspectives from the clinical, the personal, policy and research on a hugely important topic that we know is sadly not going away in a hurry. We have an exceptional panel of speakers, and hopefully we're going to cover through both what they say and from the questions from the floor, the full range of eating disorders. The format today is that I'm going to invite each of the speakers to say a few words in response to a specific question, and then we have some questions that have already been sent in, and we will invite questions from yourselves and from the people who we are live streaming to. So hopefully we'll have a not overly heated, but heated debate on topics of importance. So I'm going to start by inviting Professor Tim Kendall to respond to my question about policy. Tim Kendall is the NHS England's National Clinical Director for Mental Health. He's been Director of the National Collaborating Centre for Mental Health at the Royal College of Psychiatrists for 15 years and visiting professor at UCL. He was chair of the NICE Guideline Committee for Eating Disorders, which is where I first encountered him. Tim also worked as a consultant psychiatrist for homeless people in Sheffield, and he chaired the very first NICE guideline on schizophrenia back in 2002. So our question to you, Tim, is what's been done at a policy level to improve eating disorder services?
Okay, thank you, Dasha. For those who aren't aware, about three and a bit years ago, NHS England produced a 5-year forward view for mental health, and a very important part of that was work around children, which involved significant investment, about 1.4 billion over a period of 5 years. One major piece of work in that was the introduction of a new eating disorders programme for under 18-year-olds. What that did was to introduce for the very first time in mental health a waiting time standard. So we promised that children, young people would be able to access nice concordant care, and that they would be able to do so within 4 weeks of referral if it was routine, and within 1 week if it was urgent. And we promised that by the April of 2021 that we would be achieving that standard for 95% of children. I'm pleased to say we are reaching 80% of their children for both of those standards today. So that I've visited some of these services, and I think, thanks to those people who are running them, people like Asha, they are phenomenally different to anything I've seen before. So all good news. Now, in the adult sphere, we had nothing on eating disorders in the 5-year forward view. The 5-year forward view, I should say, was effectively co-produced with 20,000 people, professionals, service users, carers. So what they decided we should focus on in this particular instance didn't include eating disorders in adults. And I think it was a good case to say, look, if you're going to focus on anything, let's focus on children and young people first, because getting in there quickly matters. Now, what we have done for the long-term plan, which started this year, we've got £2.3 billion to invest per year, working up to £2.3 billion over 5 years. So that £2.3 billion per year, probably the biggest increased investment in mental health services in history for the NHS. But out of that, the biggest proportion of that will go into community mental health. Now, community mental health will include anything that you might think of as a serious or severe mental health problem. That will include eating disorders for adults, as well as personality disorder, people with psychoses, people with complex chronic mental health problems, and people who've got complex comorbidities. Now, what we'll do with that over the next 2 years is we're investing in different pilots around the country to try and work out how we can achieve a 4-week waiting time for adults, not just in eating disorders, but across the whole of community mental health. Now, some of those pilots will be specifically eating disorder services, and they will be expected to run a waiting time of 4 weeks. The end of that period, we will be able to then say what we can realistically achieve within the money that we've got. Now, alongside that, we've also, we're picking up all the currently NHS England specialist commission beds for eating disorders. There's about 402 of them. They cost 82 million, and we've done some pilots, one of which I've been to recently in West Yorkshire, where we've given those beds back to a lead provider. In this case, up in West Yorkshire, the lead provider has taken the money, and then they've used the beds. They've shortened the length of stay, they've shut some of the beds, and they've introduced care pathways in the community. So that will go on alongside the additional investment. So, I mean, there are lots of other things that we're doing. We're investing in new ways of working, like around Freed and so on. And really anything that really starts to look like we could do something with it, we're very keen to look at and see if we can't use it in the programme. But our aim, I need to say, is that we that we reach the same level of quality and access to services for adults with eating disorders as we have for children, but we're not there yet. Thank you.
I'm sure there's lots of burning questions. I'm going to ask you to hold your questions for the moment, but I think it's fair to say this last 5 years has been the most rapid expansion of and development in eating disorder services that we've seen probably for...
I mean, it's the biggest expansion in eating disorders, but also in huge areas of mental health, so early intervention in psychosis, crisis teams and so on. Lots and lots of different developments, and that has now reached a much higher level. I mean, you cannot believe how busy we are in mental health. And mental health is now probably the top priority for NHS England. So, and we have the biggest team for implementation and transformation. I don't want to give the impression that we have arrived. We have not. We've just started. But we have a guarantee that the money that we've got in the long-term plan will be ring-fenced for the next 5 years. So the money that we hand to CCGs will be spent on mental health.
Fantastic. It's also the envy of other countries, having talked about this in various international eating disorders conferences, what's happening here. So let's hope we can set a blueprint for the rest of the world as well with some of this. Thank you. Moving now to James. So James has experienced a major eating disorder from the age of 16, and although now well into recovery, he faced many barriers and a 6-year wait to access specialist treatment. He now works as a volunteer to develop eating disorder services, campaigns for changes in policy and awareness, alongside studying psychology and education at the University of Cambridge, where he researches understandings of the concept of resilience. Is that enough?
Yes.
I've met James in many expert reference groups, Royal College of Psychiatrists groups, cross-party parliamentary groups, you name it. James is everywhere, being an advocate for service users. So, James, our question for you is, how do you see access to eating disorder services?
Okay, so hi everyone. I'm really glad that Tim took more than a few words, because I was really nervous when it was just a few words to explain access to eating disorder services. But I could summarise it in it's very difficult, and it has been very difficult. I'm acutely aware that I'm representing sort of lived experience on the panel, and just want to reinforce that I'm only going to talk about my experience, and it is just my experience. It's not generalisable to everybody, but hopefully there are some points that I can pull out from what has been a sort of traumatic and long journey with lots of twists and turns that are helpful, because it could be really easy to go through this sort of 15 years, sort of 14, 15 years of eating disorder that I've experienced and portray it as a catalogue of awful experiences, which it generally has been, but I want to be able to say something that is useful, that maybe I could have benefited from. And even though it is just my experience, hopefully those points, those general points, resonate with others as well. And I don't think, personally, from people that I know, and seeing lots of people here from Twitter and this kind of stuff, I know that they're not uncommon experiences. So some of the things from my the whistle-stop highlights of life with eating disorders that relate to accessing services, I think going back to the beginning, I think at the onset, barriers to accessing services were a lack of recognition of what were the signs of eating disorders in the first place. And for me, they were disordered eating was tangled up with other symptoms around OCD and body image, and the eating disorder didn't present first. And the mental health problems occurred in school in the first place, and people around me didn't know that it was a mental health problem. They thought it was bad behaviour. And then later on, I went into services and shifted from sort of body dysmorphic behaviours towards food, weight and shape. And the people even within the services didn't really recognise what was happening. So if the people in services didn't have the knowledge that anorexia could happen to a young boy as well, then I sort of think no wonder people in the public don't necessarily understand that. I think that part of things has improved with awareness campaigns, and I don't think I would have had quite the same experience now if it happened again. This is nearly 15 years ago. But I think that that is the first part in terms of access, is sort of spotting it in the first place. Another part would be something that a lot of people might relate to about barriers to access in terms of weight and in terms of physical health status. So I feel like I've experienced it from both sides, having had anorexia and bulimia and still living with bulimia now. A very long time I couldn't access what was available because I was deemed to be too underweight. So I didn't have the cognitive capacity to engage with CBT, which was the only thing that was on offer in my area. I don't think that would happen now because there's evidence and research which suggests otherwise. So that's, again, another case for good research. But at the time, I was told that you have to gain weight in order to access therapy, and I had to do that on my own. Well, if I could do that bit on my own, then I wouldn't have needed it in the first place, yeah? So there's that, and at that point it was all about physical health management. So I did have my life saved multiple times in A&E, and had my potassium pumped in and all this kind of stuff sent away to no specialist psychological support, general support that I felt didn't really address me as a person. The other side of it has been when my weight has been too high to access treatment, which has been the case more recently, and I have lived with severe bulimia for a very long time, and I still have it to this day. And there was a long time where I didn't want to access services at all, because I didn't really have much hope, which I think is how I see accessing services. They have to offer something hopeful, otherwise why would you go? But I was refused the first 2 times when I tried to access services in Cambridge, and I was told that I was too medically stable to access the services, even though I was experiencing sort of 4 hours of binging and purging behaviour every day, 20 plus hours of exercise per week, a full-time job in the maintenance of the eating disorder, never mind in the recovery. And I've worked really hard to be medically stable, to avoid immediate cardiac arrest, this kind of thing, and I was not going to give that up in order to access services. I finally did get into services in Cambridge, and it happened by going to a conference and speaking about not being able to get services in Cambridge. The clinical lead of the service was in the audience. She came up to me afterwards and said, I think if you were referred now, you might get in. And so it's sort of like an audition, you know? But I really worry about the people who can't speak at conferences, you know? And it shouldn't have to be a fight to get access to services in the first place. And I'm privileged to have the voice that I do, and I said to her, well, I will take it to the media again if I don't. But that really shouldn't be the way, you know, and I don't know where I get my confidence from in terms of that, but I'm lucky for it, and not everyone has that, and I did not have it for a lot of the journey. Other sort of barriers to accessing services have been a whole set of assumptions based on the lack of knowledge from professionals, I think. Some of them relate to being male. A lot of the time I found that professionals were chasing other diagnoses because they couldn't just accept that I had anorexia as a boy. Diagnosed with multiple different things, all of which I don't really accept now. I think that there have been assumptions around being sort of middle class and having a well-to-do family that I therefore must automatically have support, which I did not, and through no fault of my parents, they were offered no support. Assumptions about being intelligent, that I understand about eating disorders and therefore I must be able to think my way out of them. I've tried it and it didn't work. And I was a medical student at one point, which I had to drop out of. That was on my records. Every time I went into A&E, you're a medical student, you know what you're doing to yourself. Why are you doing it? Yes, I knew exactly what I was doing to myself and how the potassium works, but you know, I was still doing it, and that caused more distress because I knew exactly what was going on. Didn't make it easier, I think it made it harder. And sort of assumptions around anorexia and bulimia, sort of that bulimia is not as serious, basically, and that has been something that I've had to fight against. I think there are unique stigmas around eating disorders which help maintain this lack of access to services. Just highlighting that with one example is being in a meeting, working as a service user representative, where I was kind of undercover because I hadn't introduced myself, and heard professionals saying things like, I don't work with people with eating disorders, they're manipulative. This kind of thing. These attitudes do still exist within services, never mind in the public, and I think that those things have to change, and it's a matter of training and resource for sure, but there are so many barriers, and then you add on other barriers on top of barriers, for example adding on gender, or whether it's sort of diagnosis that there's not much support for, like binge eating disorder or ethnicity or culture. It becomes more and more of a fight, and I think that that's just not really what you need. You shouldn't have to fight for it when you're already really fighting. A couple more points. I'm taking the privilege of being the sort of lived experience person that I can't condense 15 years into 2 minutes. But I think it really matters actually, not just about access to services. I don't think it's good enough to tick a box saying you met for weeks. I think what matters as well is what happens when you're in the service. It's all well and good being able to get into services to access support, but what is that support? Is it of good quality? Is it what you want? How is that support collaborative? Because a lot of my experience in services was confrontational. I got into the services, but it was, you will stop your behaviour or X, Y, and Z will happen. And it sort of didn't really form an alliance, didn't really help me to get better. So what I had eventually was a bit too little too late, and we didn't have the relationship to make much progress. So I really think that's important. Last couple of points, there'll be a lot of talk I think tonight about early intervention, and I just want to highlight that the vast majority of people with eating disorders will never ever have an early intervention, because that time is gone. And I think that it's really important to remember what we offer to those people as well. And kind of the word intervention, I didn't really want intervention. Intervention seems very invasive. I wanted somebody to care and I wanted help. I didn't want intervention. When help did come, it was intervention that was forced. It was, you will go to hospital, you will be sectioned if you don't do this. And I think that the nature of the help is really important. I think it should be help and care, not necessarily forced intervention, and services need to meet you where you're at rather than imposing things. And a lot of people don't necessarily want to change. There needs to be a space for those people as well to be in a service without being intervened with, being held by a service. And I want care, like when I go to the GP, they say you're the expert, blah, 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 you're on all these committees, I saw your name on this guideline, blah, blah, blah. And I know that I probably know more than the GP, but I still want them to care, and I still want them to acknowledge that I'm a human. I think every single moment of help seeking, in light of that thing about early intervention, every single moment of help seeking is an opportunity for early intervention in that moment. Eating disorders have long duration, they're complex, they involve relapse, they're up and down, and I think that every time someone comes forward to help, whatever stage they are on their journey, they're equally valid of having early intervention provided, whatever the picture of their illness is now. And I think that very often when I've gone to get help, the responses that I've had have been so unhelpful in terms of being told, for example, bulimia is just attention seeking, or just having real misinformed opinions, or you're not sick enough to access that service. And the end product is that you feel unreal and that your problem is not worthy of support, and then you don't go and seek help again. And that, for me, is really anti-Hippocratic. It's doing harm, I think when people come forward for help, it's a super vulnerable moment. What happens in that point is really important. And it's a miracle when people come forward for support, because they might have heard all these stories that it's so terrible. Anybody watching this and me saying it's all been really, really awful for me, I would still say go and get help, and if you don't get it, it's not your fault. But I think that we really have to think about what happens in those key moments. And this thing of doing no harm, it is not harm-free to go to the GP and be sent away with no validation. It is not harm-free to stay on a waiting list. That is not a harm-free place to be. You probably will get worse. It's not harm-free to move area to get treatment. It's not harm-free to be incentivized to lose weight to access a service. And it's not harm-free to be scared into getting better and never offered a positive reason to get better. I never had a conversation about what do you want your life to be like. It was all about, you don't want to do this because it's awful. So where is the hope in that? So access, really, my summary for the whole thing is that I don't think, when I think of access, I think of going through security at the airport to access that area, or climbing, you're accessing the highest peak, that kind of thing. I don't even think it should be access. I think services should be offered, not access. It shouldn't be a fight to get into services. And I think that it should be that you go for support and it's offered, or somebody identifies that you have a problem even if you didn't go for help, because they're knowledgeable about it, they spot the signs for you, and they encourage you. So I think that I would just reshape the idea, the way we think about accessing services, because now it is a fight, and there are so many barriers, and the positive message is what can we do to remove as many barriers as possible. It comes from research, it comes from training, comes from resourcing, and other people will be able to talk about that a lot better than me. But if we manage to do that, then hopefully people won't have quite the same experience as I have had. Thank you.
Thank you, James. Thank you for summarising 16 years in a few minutes, but also I think reminding us all how incredibly valuable personal experiences to what we do and what we learn and how we do things. So thank you. I realise it's only your story, but there's so many important messages in what you just said. Thank you very much. So moving now to research, which you mentioned a few times. Our next guest is Dr. Francesca Solmi. She's an epidemiologist in the UCL Division of Psychiatry. Her research interest is on the application of causal inference methods to understand what causes eating disorders across the life course. She's also interested in studying long-term outcomes of eating disorders and disordered eating in the general population. Francesca currently holds a Wellcome Trust Sir Henry Wellcome Fellowship to study whether inflammation contributes to increasing a person's risk to develop an eating disorder. Francesca. Your question is, what is the state of eating disorders research?
So it's a bit of a question, but I think I want to focus on some of the good things that I can add to research, but also mostly on some of the challenges that the field of eating disorder research is currently facing. So we have had a lot of very positive research and innovative research that's come out in the last few years. There's been an increase in longitudinal research for eating disorders or early life risk factors. We have GWAS, genome-wide associations, such as genetics, study of genetics of anorexia nervosa and study of the genetics of eating development now in the near future that they're working on it. So there's a lot of new developments in the area about early intervention programs in a minute. So there's a lot of good research coming out, but there's also challenges. And one of the biggest challenges for eating disorder research in terms of the quantity of the output that produces lags behind a lot of the other mental health conditions. And one reason for this is that there's very little funding that gets given to eating disorder research. So there has been a MHQT, the mental health charity, an MHQT report that has shown the proportion of mental health funding that goes to all different sorts of mental health conditions and eating disorders, along with others. It's not just eating disorders so far, it's another consistently comes out at the bottom in terms of amount of research funding that is devoted to. So I think in the previous report they tried to quantify the amount, what proportion of total UK mental health funding gets given to eating disorders, and it was 0.4%. So that amount was 7% for schizophrenia in comparison. For depression, it's about 5% for schizophrenia and to almost 2% for autism. So in a way you would expect more funding for depression because you know it's very highly prevalent, but when you compare the prevalence of eating disorders and schizophrenia and autism, they're very similar, and actually perhaps schizophrenia is more rare than eating disorders. So when you try to compute then how much money is spent per person with eating disorders in the UK, they calculated it's about 15p per person with an eating disorder, which is shocking in my opinion. And if you compare it with autism, so we're comparing conditions that have similar prevalence, that's about £4, which is still shockingly low, and £61 for schizophrenia, which is the most highly funded. And not to mention this is low funding across the board for mental health conditions, but 50p for each person with eating disorders is quite shocking. So with some colleagues, we tried to look at how this translates in number of outputs that get produced in terms of papers per year. So we looked at how many papers on eating disorders were published last year, and this was about a fifth of all papers published on schizophrenia and a third of all papers published on autism. So to compare, again, conditions with similar prevalence. So if we have less research, it means that we know less, and we just heard James talking about how new findings have changed its ability to access certain services. We need research to improve access to eating disorder services. And something else that seems to happen with eating disorder researchers, and if there are eating disorder researchers who might be familiar with this, is that they seem to get published less in the most important journals about psychiatry. So another thing that we looked at with colleagues is how many papers on eating disorders were published in the most widely read psychiatry journals, and again, it was shockingly low. And you think, if fewer papers overall are published, then you would expect that there are fewer papers published in these journals, but we looked at the proportion of the overall numbers, and the proportion of eating disorders papers published in these big five-factor journals was a lot lower than that of any other disorder. So there seems to be a certain inequality towards eating disorder research in a certain direction. So it's a bit of a cycle where there's less funding, we produce less, it gets into the more niche, the more specialistic journals, fewer people see our research, and then it gets the idea that maybe eating disorders are not that important if there's maybe journals with the greatest audiences don't see this research. And then what happens as a result? We get less funding. But also in terms of, so I work with a lot of survey and general population data, and it's very hard to find big cohorts or big surveys that include data on eating disorder. And I think the most blatant example was the last adult psychiatry morbidity survey in 2014, which didn't include a measure of eating disorder. And that's a missed opportunity to calculate how many people have disordered eating or eating disorders in the population, what's the level of need in the population. But we know that eating disorders are very serious. We know that when epidemiologically, if we look at the very strict definitions of eating disorders, about 5% of the population will have an eating disorder, have an eating disorder. And when we start to look at the subtractive behaviors or disordered eating, that's a very large number in the population. And eating disorder comes with high physical, mental health, comorbidity, high rates of mortality. We know that recovery rates could be improved, could be better, so we do need research into this, and eating disorder affects everyone regardless of ethnicity, age, BMI, socioeconomic status, and so on. So I think in terms of research, we need more research into new therapeutic approaches, but also evaluating the effectiveness of current therapeutic approaches. We need research into what causes eating disorder if we want to start create preventative measures, because we need what caused something to be able to devise prevention strategies. We need to know what happens in the long term to people with eating disorder, even after their recovery. And we need to know about new types of eating disorders, so there's increasing talk about orthorexia, and of course, very little research still. But also, we know there's a big disparity in the amount of research that get published on anorexia nervosa versus bulimia nervosa and binge eating disorder. We know more about anorexia than we know about binge eating, so we do need to know more about eating disorder across the spectrum. So, but for this to be achieved and for people's lives to be improved, we need to stop consider eating disorders as a niche specialty within psychiatry and give it parity or esteem with other psychiatric conditions and start to invest more in research in eating disorder.
Here. I'm going to move this on so that we get time for questions from the audience. So our next speaker is Dr. Karina Allen. Karina is a senior clinical psychologist at the South London and Worsley NHS Foundation Trust, Eating Disorder Service, and a visiting senior lecturer at King's College London. Her current work is focused on the successful rollout of FREED, you heard Tim mention earlier. FREED stands for First Episode Rapid Early Intervention for Eating Disorders within the UK and beyond. She's been supported in this work by an NHS Innovation Accelerator Fellowship.
Thank you very much.
Do you want my question? Oh, yes, I have a question for you. How can we improve outcomes for people with eating disorders?
Thank you. And I think I really want to start my answer by acknowledging that there is no single answer to that question, and all of the points raised this evening are going to be part of how we improve outcomes. And so too is input really from everybody in this room, so researchers, clinicians, those with the lived experience, policymakers, NHS England, but also all of you out there who have an interest of some type, where the community sees eating disorders. All of this needs to come together so that we're drawing on the different components of experience and expertise to bring about the changes that we need. We know at the moment that certainly for adults with eating disorders, outcomes are only moderately successful at best. And it's a really depressing position to be in, despite decades of efforts to improve treatment outcomes and improve the treatments that we have available for adult eating disorders. The situation of children and adolescents is more certainly not the evidence-based treatments that are recommended in current clinical guidelines. So one of the initiatives that our service has been working on over the last 5 years is FREED. And as noted, this is first episode rapid early intervention for eating disorders. And this was developed across the Moors for Eating Disorder Service and King's College London, very much in collaboration with young people and those with a lived experience, to provide a dedicated early intervention pathway for 16 to 25-year-olds who had an eating disorder of less than 3 years duration. Now this is only one subgroup of those with eating disorders, and I absolutely acknowledge that, and we'll come back in a little while to the fact that we need to think beyond this group as well. But what FREED really tries to do is provide rapid access to specialist care for this particular patient group, but also tailor the evidence-based treatments we have to the specific developmental needs of these young adults with a relatively recent onset eating disorder. And this includes really straightforward things like being very proactive and flexible with how we try and engage with young people who are often really nervous about coming to a specialist service. Being a little bit flexible with how we communicate, so we'll send texts instead of sending letters. We'll offer appointments at different times, which is kind of this crazy idea that not everyone can come in at 12 o'clock on a Thursday. But we also do things like really try harder to enrol families where it's appropriate to do so, which is standard for under 18s, but often really drops off once people hit this 18-year mark. We pay a lot of attention to transitions, so transitions out of childhood services, out of school, into work, and especially around university, because this is an age group who are often moving between university and home, and can often require input from two services, and really provide guidance on how we can do this safely and effectively, rather than having patients really get lost between two different geographical areas. We talk more about things like social media and identity formation, which are relevant across the lifespan, but again are particularly relevant often to this younger group who've had an eating disorder for less time. FREED has been really thoroughly evaluated at our own service and then around the country, and it's now running 8 eating disorder services in England. We know it is effective at reducing waiting times and at improving clinical outcomes, and it reduces the need for day patient and inpatient care by around a third, which is really great for young people, so fewer need to go away from their normal lives for intensive care, but it also saves NHS money. What we're trying to do now is continue scaling FREED so that it is the norm in England, in Scotland, in Wales, in Northern Ireland, but also internationally as well. So that we really get away from this situation where there is a postcode lottery in how easy it is for you to access services, where you have to fight really hard or speak at conferences in order to get the services, which is so terribly unfair. We do also recognise though that early intervention is part of the solution. It's not the whole solution. We have seen in other areas of psychiatry, particularly psychosis, that early intervention can change the way a particular presentation is viewed. And historically, psychosis really was viewed as a difficulty which you didn't recover from. And psychosis services are about managing chronic symptoms and long-term disability. And early intervention has changed that so that it's now really normal to think about promoting full recovery, full living to potential. And that is what we want for eating disorders. And the more people we can get through early intervention pathways, the more we'll change the long-term position and the long-term outcomes for these disorders. At the moment though, we really want to make sure that we're thinking about how we improve access for everyone, not just those in that younger group with a relatively recent onset, and tailoring treatment to the needs of people across different disorder stages. There's been some great research recently showing that core eating disorder treatments like CBT are effective even if you've been unwell for many, many years. So we know that these presentations, regardless of how long you've been unwell, can respond well to treatment. But often there are slight differences in what people need depending on how long they've been unwell and what people want, just based on their own personality and their own life. So I think my take-home message really in how we improve outcomes is early intervention has to be important, and working as I do with FREED, we think that is a really key part of the solution. But so too is putting the needs of everyone with an eating disorder on the table and trying to tailor what we provide so it isn't a one-size-fits-all and everyone can access care appropriately and quickly. Thank you.
Samira Sina is a consultant psychiatrist with over 15 years experience in the NHS. She's been an eating disorders consultant psychiatrist in Sussex. Currently she works as a consultant in the private sector. Her special interests include stress management, eating disorders, transcultural psychiatry and stigma in mental health. Samira is the founder of Living Life Stress Free Limited, a registered college of the Complementary Medical Association, providing stress management workshops and courses for professionals. She's a member of the Royal College of Psychiatrists and a fellow of the Complementary Medical Association. Shamila, our question for you. Our question for you. How can inequalities affect access to eating disorder services?
Thank you. I think I'm going to echo the theme today, which is funding. And I'm really happy that Professor Kenton is here, so he can take this message back. What I feel, working as a consultant psychiatrist, as an eating disorder department, I felt that inequalities in funding played the biggest role. Because it's a well-known fact that mental health services are not as well funded as the other fields of medicine. So we are lagging a bit behind, but I'm really pleased to say this is improving. So what happens is the inequalities in funding, what happens is most of the services are stretched, particularly in the NHS. So what happens is diagnosis like binge eating disorder or eating disorder not otherwise specified. So some of these people suffering from these conditions don't stand a chance to access services compared to anorexia. And even bulimia, patients who have normal body weight or who have more than average body weight, they usually are turned down from services. And a couple of years ago, I did a systematic review looking at the treatment-seeking behavior and treatment-receiving behavior among ethnic minorities in Western countries. And I felt that coming from ethnic minority background also is a disadvantage because there is a lot of clinician bias and a lot of referral bias because of the lack of awareness among GPs, among psychiatrists and other practitioners. There is a consensus that eating disorder only affects the certain ethnic groups and not, for instance, doesn't affect the blacks, doesn't affect Asian communities, or doesn't affect, say, in America, as the Hispanics. They were looking at that in their research. So what happens was clinicians are poorly informed and symptoms are dismissed. So that is an inequality. Now, I also came across, and I echo this fact what James mentioned, is the fact that men are also at a disadvantage point because men are, eating disorders is usually identified as a disorder present in the female population. Actually, research has shown that 10% of the sufferers are men. So, but if you compare the treatment seeking, the access to treatment, that is not corresponding with the actual, the prevalence of the condition. And the other thing I really found was, this is particularly relevant, maybe not in the UK, but in other Western countries, affordability of treatment is a big factor in accessing treatment, particularly people who are on insurance in America. Like mostly insurance providers, they will not cover certain eating disorder conditions, or they will not cover the length of the treatment. So that is definitely a big factor. Now, the other thing that I would like to mention, particularly relevant in ethnic minorities living in the Western society, is the concept of acculturation. So I did a course on transcultural psychiatry. That's one of my special interests. And I came across this term called acculturation, which means it is the process of integrating among cultures and individuals of different cultures coming together. And people who are more accultured, they had a better chance of accessing treatment. Language is a big barrier. And sometimes, unfortunately, certain cultures, they don't, there is a stigma associated with mental illness, including eating disorders among some cultures, and they will not seek treatment. Families are not very forthcoming in treatment seeking. So I think that these are a combination of factors. would say at this point. Thank you.
Thank you very much. And that, of course, can lead to stigma in particular, enhanced stigma in some populations, can't it? And our final speaker tonight, last but not least, Nadia, is Nadia Craddock. So Nadia is a body image researcher and a PhD candidate at the Centre for Appearance Research at the University of the West of England in Bristol. Nadia is interested in identifying avenues for macro-level change to foster positive body image and to help in the prevention of eating disorders. Nadia sits on the Academy for Eating Disorders Diversity, Equity and Inclusion Committee to the Board of Directors and produces the Centre for Appearance Research's podcast, Appearance Matters, which she co-hosts with Jade Parnell. Nadia, your question, what can be done for eating disorders beyond the clinic, or possibly before the clinic?
Thanks, Dasha. Well, that's a really big and complex question, and I'm not sure how well I can answer it in a few minutes, but I will see what I can do, and then hopefully we can discuss all the points, maybe any questions. So I think up until this point, we have laid down the foundation as to why we need to think about eating disorders beyond the clinic. So just to recap, I think quickly, we know that a sizable proportion of people struggling with eating disorders do not receive adequate timely specialist care. So they're not even coming through the door. We then know that eating disorders are notoriously difficult to treat, particularly when they become chronic. And with my lived experience, how come for a second, it's miserable to everyone involved, right? And then when we think then of the society we live in, and this is where my research comes in, we live in a society in which disordered eating behaviour and cognition is encouraged, promoted, rewarded, right? Like we celebrate thinness, we kind of associate thinness with moral value, which is wild when you think about it for a minute, because our weight is more to do with our genes than anything else, right? We also live in a society in which weight stigma is rife and rarely challenged. I think the example of the cancer research campaign, whereby there's the idea that obesity causes cancer, is an example of which we are kind of endorsing weight stigma. It's a weight stigmatizing message. I think it's simple science that I think we might see like a correlation between obesity and cancer, but 101 science correlation is an equal causation, and the message is inherently stigmatizing, right? But there's nothing useful and valuable about that. And then we also live in a society in which now things like laxatives are sold in like millennial pink by influencers with hundreds of thousands of followers, and this is terrifying to me, because I think if you think 10 years ago, 20 years ago, laxatives were a really difficult, like shameful thing to buy if someone was struggling with an eating disorder. Now it's glossy and it's cool, and that is not okay. That is not okay, and these things absolutely need to be clamped down on. And then maybe the last thing when we're talking about the society that we live in, and we think about diet culture, and this is kind of a phrase that's really useful, because we have this idea that we can really manipulate our weight. It's a huge billion-dollar industry. It's rooted on failure, and it's normalised. Everything, like cutting out food groups is normalised. Not eating at certain times of the day is normalised, and we kind of give it like a well done. We're kind of engaging in a health behaviour, and it absolutely is not. And I think the reason that we need to think about some of these societal issues related to disordered eating behaviour, related to weight stigma, the ideal of thinness, is that of course eating disorders are not just about body image, they're not just about what we eat and not eat. But it's very clear within the evidence that weight stigma, body satisfaction, and dieting are all predictors of eating disorders, right? And the minute our society is kind of endorsing that and celebrating that, we're in a perfect storm for eating disorder behaviour. So in terms of what we need to do beyond the clinic, we need to be tackling weight stigma head on. Okay, we're not going to do anything fast and move eating disorder work forward if we're not tackling weight stigma. We cannot ignore that. We need to shouldn't be allowed. And if you want to know more about that, there's a team over in Boston, the Strategic Training Initiative for the Voting Region School, the Stripe over at Harvard, are doing some really incredible policy work in that area to at this stage move diet pills behind the counter within stores, and for children under 16 not to be able to buy them. Okay, so really like the first step in that area. So what else do we need to do? So I think that there's so much work that we need to do, and I think it's almost overwhelming. But yeah, I think we need a lot more. So we need to be tackling weighting head on. We need to be teaching media literacy. We need to be working with our businesses, with our brands, and not kind of just like letting those kind of things go on the wayside. And we need to think at all of these levels, at our quality level, and then kind of the conversations that we have ourselves in terms of how are we kind of perpetuating this culture that is kind of endorsing and celebrating disordered eating.
Thank you, Gary. So now you've heard from all our speakers with their well-argued and sometimes passionate views on a wide range of topics. It's over to you guys and questions from the floor. Shall we take from the floor, or do you want to do these ones on there? Yeah? Oh, okay. So we're going to wait for the microphone to come to you before you ask your question.
Can you point?
I will. But I just want to make sure that I see hands. So there's a hand here, first of all, and then...
Hi there, my name's Lorna Collins. I have a more of a comment than a question, because I was speaking to Andre earlier and he said it was okay to give my sort of success story, really. I hope I can call it that. I really relate to what you were saying, James. I am called a champion voice of service users as well, and I was fascinated by your piece, Karina, about the care model that you proposed. I'm working with a very medical team that helped me get well after 18 years of relapsing and going in and out, detained in hospitals across the country and in France, where I lived. And so I've seen the worst side of eating disorder, so-called treatment. But I had then found an extraordinary type of treatment in Oxford at the Warneford Hospital with Agnes Ayton and her team. And I finally learned what well meant, and I became healthy, and I have retained that health, and I live in an amazing way. But what I want to sort of suggest is that it is possible to build a new care model that can be accessible. It's the one that I'm working on with the Oxford team is based on not just weight. I was admitted at not a very low weight. That wasn't why I was admitted, because of my weight. So that's an example that it is possible to get help without having to be about to die from malnutrition. They map each patient's journey onto a formulation that is individualised and personalised treatment for each person. Care exists in the community beyond the hospital. I know it's really important that we've talked a lot about hospital treatment, but the idea of making a form of treatment that it prevents having to go to hospital, a treatment in the community, is something that we may need to address. Also, using the arts in treatment. That was my key medicine, is art, painting, poetry, reading. Is just really crucial. So we could maybe add that to the list of things that might work. And also working with comorbidity. We haven't touched on that in any length yet. But the Oxford model works on each individual case. I could go on, I won't go on. All I'm saying is I'm working with the very team that helped me get well, and we are hoping to expand that care model to other hospitals all around the south of England.
Thank you so much. And highlighting, I think, two really key points. One about And I think there's always a tension, isn't there, between offering evidence-based care and one of the things that we're all trying to do is to make sure we use the best available evidence, but also personalising care and making sure it fits the needs of the individual, and that's always a tension, so thank you for raising that. Speaker at the back there, thank you. No, sorry, right at the back. Sorry, I'm being trying to keep the order. Noticed hands in.
Hi, so my name is Fumi, and I've had eating disorder for about 25 years, and it was only about 10 years ago that I sought help. So at the time that I sought help, I kind of had quite a rapid introduction to the system. But that was because at the time I sought help, I was put on a waiting list, and then only given more intensive help once my weight got really quite low. And it stayed that way for 9 years up until last year. So I had sort of treatment on and off probably for about 4 years. But in the end, after all of that and trying to get more help, essentially what I did was begin refeeding and recovering myself with the support of my brother. And the reason I'm mentioning this is because I don't know how much attention is given to the experiences of people that have recovered outside of services to see how they manage to recover outside of services. So I don't consider myself recovered at the moment, I consider myself in recovery, but I think there's a massive group of people recovering and recovered who probably have a lot of input that they can give into kind of how people can recover. And I say that as well because one of the things that I learned myself outside of treatment was about extreme hunger, which is something I never learned within treatment. And I think there's some things that most of the things I've learned in recovery have been because of the experiences of people that have recovered and learning sort of what they went through physically in recovery, which helped me not relapse whilst I was in recovery. So I'm just kind of wondering about research that might have been done into the experiences of people that have recovered outside of services, because it doesn't always happen for people in services like it did happen for me.
Thank you for that comment and for highlighting something that I think has been on the radar. I think there was a debate a few years ago at the European Eating Disorders Society about whether treatment actually made any difference, because there were some studies coming out of Scandinavia showing that people who didn't have treatment didn't do terribly differently from those who did. I don't think that the message overall, the conclusion overall, was that the evidence was in support of treatment, but clearly it's not going to work for everyone. And as we've heard, different things work for different people at different times. So I think we could generate a whole research agenda from some of the conversations that we're having tonight. So thank you very much for your comments. Did you have a question for anybody? Or was it or you just wanted to comment?
It was more for the, it was actually more for the researcher and for the lady that works at the Maudsley.
Yeah.
Yeah.
And I can say a couple of things. These working. So I think we're really aware actually of how important it is that we tap into people like yourself. What we've struggled sometimes with is how to find you, and we are trying to use social media more so that we're not just talking with people within the clinic. As I spoke about, as others have spoken about, we know it's really hard for people to get to us actually, and so there's also this issue that there's many people out there who never get over our threshold. So we are trying to navigate the world of Twitter and Instagram, and probably not doing that well, but making an effort really to have a more community platform where we can have these conversations. And you know, we've got people who've come in and spoken with us about ideas who've never been our patients, but we've connected with that way. Some of the research we're doing is also in that area, and sort of sticking with that theme of social media, just as an example, a recent student of mine really did a qualitative study on how people have used social media to influence their recovery separately to treatment, and trying to pull out, you know, the challenges that social media are about, but also what people experience as beneficial. Clinicians, we can sometimes be quite critical of social media, and lots of people find it helpful. So we are trying to tap into these, but I appreciate you raising how important it is.
Thank you.
Peter Lyons, I've got a daughter who has what has become an eating disorder, and very much overweight. Now, she's also on antipsychotic drugs, and I wonder of the people sitting up over there, what has your experience been of trying to overcome the barrier of, oh well, the psychiatrist's
Are you saying that? Sorry, are you saying that your daughter's being offered antipsychotics as a treatment for eating disorders?
I'm sure you're familiar with the contraindications of antipsychotics. One of them is weight gain.
No, I mean it's a huge side effect
Yes.
of antipsychotics.
What I found in another area, an area, which has a sleep disorder, and the sleep disorder people say, well, we can't handle this because she's on this antipsychotic medication. And I just wonder to what extent that response prevails in the eating disorder area.
Okay, well I'm going to answer very briefly and then James is going to say. Okay, so first off, antipsychotics should not be used for eating disorders. There's no evidence that they have any benefit in that context. If somebody is on an antipsychotic and they're gaining weight, and they're on the antipsychotics, say for example because they have a psychosis, then what they should do is try and change the antipsychotic and find one which doesn't increase weight. And that sometimes takes time, but absolutely should be done. Weight gain of the kind you see with antipsychotics is one of the reasons that people with psychosis die prematurely. They get weight gain, they get cardiovascular disease, they get diabetes, etc., etc. So, there should be a plan to change the antipsychotic to one that's less likely to do that.
I think there's the point about the antipsychotics, which is something that I relate to from my experience when I first had anorexia and was offered no specialist treatment. I was put on a lot of antipsychotics, and it was justified for some reason, and I didn't really understand why, and I had no choice about whether I should take them or not. And it was very effective in helping me gain weight, which I think was the motive. But I think there's the main point that I'm taking from what you're saying is about when one service says, oh, it's that clinic's responsibility to deal with that, and then psychiatry says it's that, and somebody else says it's that. And in my experience, in terms of your question about is that the case in eating disorders, as a patient that has been the case all the way through, especially when it comes to management of physical health problems. There have been a lot of times when I've been at very high risk, and I've known people and friends who've sadly died because somebody hasn't taken responsibility for monitoring electrolytes, for example, and my eating disorders team said it's the GP's responsibility, and then the GP was like, no, it's the eating disorders clinic responsibility, and it was me in the end that had to find the solution and force the GP to do it, and jump through loads of hoops of having to call and make the appointment, and forcing them to do it every so often, and if I didn't make the appointment and go along, they would never follow it up. Nobody would follow it up, or the eating disorders people would tell me, you've got to go and do your blood test, when I couldn't really get out of bed some days, and like the hoop of just going to jump through, just going to the doctor was too hard. So the consequence of that was that I was put at extremely high risk, and every time I managed to have a blood test, I was like whisked into hospital, bypass everyone else, and I'm really lucky that I didn't fall through the net even more, So I think that there is, especially when you become an adult, the transition in terms of not just between services, but in approach, in terms of it's now your responsibility, means that nobody else really takes the responsibility and you can really easily fall through the net. So I think that is the case. Also the point that you said about people outside of services, I think kind of might relate, because what I was thinking when you were speaking was about things that helped me in my recovery, and a lot of them were not in services at all, and that was always seen as an independent journey. Like, I found mindfulness through a dialectical behaviour therapy group where you have to eat the raisin and all that stuff, and I thought, this is probably quite good, this is probably what I need. I find it really, really hard, so there's probably something in it, and I was like, oh, I would like to do more of that, and they were like, well, go and find it yourself, So I then had to go to the Buddhist centre myself, and that was not seen as part of my treatment, and I didn't have any support with that. And then later on I found yoga, which was the antidote to compulsive running, which I gave up and never looked back eventually. But to me, those are really big parts of my recovery that I don't really, or at the time, didn't have a space to talk about in the therapy room. It's was always very focused on behaviour and weight and all that kind of stuff, and not on the bigger person. What do you want with your life? There are so many things that we don't talk about in the therapy room, and just one example, last example, is, for example, nobody talks about sex. And that, there's a massive implication in terms of, in my experience, there's a massive implication in terms of sort of physical changes with eating disorders. And I'm not talking about sexual orientation, I just found it very difficult having a human sexuality, not about who I was attracted to. And I never was asked about that, and I did an equality diversity training with an eating disorder service and asked them, do you talk about this? And they were all like, no, never talk about that. That's separate, that's for another clinic, that's for, that's for go and get counselling for that, or whatever, somewhere else. And so I think it's all about the whole person, not having to send the patient or the service user here, there and everywhere, and then having to take all the responsibility themselves. Services need to meet you with and share that responsibility a little bit, because, a bit of paternalism sometimes can save lives. Even if it's not in that, I don't want it to be in that intervention kind of way, but if my doctor could have taken on scheduling blood tests for me and chased me up when I didn't have them, then that could have taken me out of some really risky situations. Yeah.
Thank you.
So,
Thank you.
important message about holistic care. Absolutely. Thank you. Next question up there.
Sorry.
It's fine. I didn't see your hand. It was the lady behind. Why didn't you
Hi,
negotiate between you?
Roya. I just want to say thank you. First of all, this has been really interesting. I'm kind of coming out as like a generally interested person who might want to go into working with people with eating disorders in the future. So I found it really interesting this evening hearing different ideas around recovery. And also kind of thinking about, you mentioned orthorexia and researching that, and also this sort of body image idea. I've noticed kind of, this is sort of personal experience, that a lot of people I know who've been through eating disorders and been quite open about that, then seem to go down this path, which I feel is sort of very trendy at the moment, of this sort of like wellness, fitness, vegan, exercising, posting all on Instagram. And I'm just wondering how that maybe ties into the role of recovery, whether that's a sort of healthy idea of recovery, and just how that all sort of ties together.
Do you want to pick a specific person to respond to that?
I mean, anyone who's interested.
Why don't I start with Francesca, given that you mentioned orthorexia?
Yeah, I think in terms of research, there's more research that is coming out that there is an association between these behaviours and disordered eating. I'm not a clinician, so I don't know much about the recovery process and the therapeutic process, but there's not much yet on these behaviours because it's quite a new condition. But there's been evidence that shows that people who have engaged in clean eating or are vegan, they don't just do that for ethical reasons, they might also mask disordered eating behaviour. So we definitely, this is like a broken record, we need more research into that.
I might just add, if it's all right, I think you've tapped into a really key issue in that as a field we're really poor at agreeing what recovery is. We have research definitions, but they vary as well, and studies continue to define it in different ways, but they don't always fit with kind of the lived experience and what matters to people. So it's a really big issue, and if we don't know what we're working towards, it's hard to get there. But I think building on the research that Francesca referred to, we often see clinically that what you described is maybe a step on the journey to recovery, and it's progress, and we will roll with it in that sense, but we perhaps would see that people who go on to maybe a fuller recovery also manage to leave some of those still quite driven and obsessive eating and exercise routines behind. Not all do.
And
something around social media.
where's the hand?
I mentioned something around social media. Because I remember 20 years ago, a colleague of mine, she was looking at the internet to check, what the social media is like on eating disorders. And next to the awareness around anorexia, there was an advert that popped up to say, lose weight, take diet pills. You see? So how the media interprets eating disorders, especially people who are using Instagram, who are using Facebook, and the other social media, they responsibility around what sort of messages are popping up, particularly the adverts, because the weight loss is a huge booming business, diet pills. So, with all the good intentions as a clinician, even if you advise patients to go onto a website to check, you don't know what they could land up, what website they could land up in. So generally that is a problem, I would say. I think to be on the safe side, it's better to stick with the NHS, website, NHS.net or NICE guidelines, or those are probably the safer ones which don't have any adverse at all.
But I think, as Nadia was saying, I think we're also dealing with shifting culture. Cultural norms are changing around these things. 20 years ago, when I started in the field, veganism was very rare, and it's not anymore. So, at least what's normal is changing all the time. So that's going to influence how people perceive recovery as well, isn't it? Yes.
Yeah, I just wanted to jump in really quickly because I'm a yoga teacher, which is a bit of a cliche and relates to what you said, and I was a vegan for a very long time. And I think one of the big achievements in my recovery recently was giving up veganism and hoping that no yoga students of mine are watching or ever see that, because you've got to cultivate the image, But I'm very into Instagram, and I think that I echo that point about maybe it's a step on the journey. So for me, the yoga experience I found was a way to encounter my body in a slightly more healthy way. Yes, I was doing hot power yoga like every day of the week, but slowly over time I've toned it down, and that wasn't as bad as running 60 miles a week and running on fractures and going out for a run and ending up in hospital, So it's slowly over time softening, and I think that's part of the journey, and it's becoming more and more helpful and less unhelpful for me. And I see that with students, people can come to my class and use it as a form of self-punishment. They can come to my class and use it as a form of nurturing and pushing themselves maybe, or relaxing. And it's really hard as an observer to say who's doing what, but sort of listening to people in terms of what's helping them or not is really important as well. But I would say that maybe there's a lot of stuff around social media, and for me personally, because I'm here talking about my experience, I guess, I negotiate that quite carefully, because if I post, it's not a surprise that my most liked picture on my Instagram is me doing yoga with hardly any clothes on, And so if I want to get more likes and more followers and get my message out, which the message accompanying the pictures is usually a really positive mental health one, I could go down that route. Is that going to be helpful for me? No. So I try not to do it, but it's always a bit of a negotiation. And like you said, there's things like strong is the new skinny, all these kind of things. Maybe they're slightly more helpful or slightly less harmful, but hopefully it's part of a step along the journey.
Now, the lady behind you, breathe in, thank you.
Hello, thank you for coming to speak. I find it really interesting. I guess my question, I'm a trainee psychodynamic therapist, and I wonder about the space for kind of other talking therapies in terms of eating disorders, and I guess in particular psychodynamic therapy, and what's the relationship?
Who wants to respond to that?
I can make some comments. I will say at the outset, I'm not a psychodynamic therapist, so I say with that as a caveat. I think we have to be guided by the evidence base, but that doesn't mean the evidence base has scope to be added to be revised, to be changed. We know for anorexia nervosa in particular, there's increasing evidence that actually have a number of therapies that are similarly effective. We don't just have CBT anymore. A recent German study was comparing CBT to psychodynamic psychotherapy, and psychodynamic psychotherapy was as effective. However, it took roughly 2 years to bring about effects compared to roughly 6 months. But some people will respond perhaps better to that approach than others. We've also got the Maudsley anorexia nervosa treatment for adults developed out of our service, which is more of a cognitive interpersonal model. And I think we've really recognised that there is a lot more to do to improve the treatments we have, and if psychodynamic psychotherapy can fill that gap, then brilliant. As clinicians in the NHS, I think we do have to be guided by the evidence and the clinical guidelines, but that doesn't mean we can't continue to change them.
And I'll just add that there is a psychodynamic psychotherapy recommended by NICE for young people as well, as an alternative when family-based treatments don't work. So it's there, but I think I want to come back to the research. It's essentially the evidence base is only as good as the research, and it's an area, psychodynamic psychotherapy is an area where the research has been less than in other types of therapy, and that's probably one of the reasons that it's not prominent at the moment.
So, CBT is kind of generously funded and kind of generously researched in psychological therapy, so I guess that's something to think about.
So you may need to change that.
Yeah, go and do a study. We would love to see it.
James,
I wanted to jump in again, sorry, because I'm really passionate about psychotherapy and longer term work being available to people and sort of getting away from a one-size-fits-all model. And I think that when I finally accessed treatment, I was put through CBT first, without really being asked, just because it was the first thing on the list, and it wasn't really appropriate for me, and I found that I failed. You know, I said to myself, I failed this because it didn't work for me, and it made me feel worse and less hopeful. So I would sort of go with that point about the evidence base, but for me, the most consistently evidenced thing is the therapeutic relationship, you know, across all the things. So if you don't have the relationship, nothing is going to work. Doesn't matter how fancy it is, however good the manual is, whoever's pushing it, or however well funded it is. If you don't have the relationship, it's not going to work. So I think that has to be established first as part of the therapeutic process, and establishing a relationship isn't a manualised therapy, unfortunately, but it is the fundamental thing. And I also think that in terms of the evidence, that the best source of evidence is not the published literature, not to disrespect anyone, but it is the person in front of you. So in terms of what might work most for them, what are they telling you? So I would always refer, that always trumps any sort of guideline of what should come first or second for me.
Thank you, and thank you for the observation. We're running out of time, but we've got a couple more questions. The lady there.
Hello, good evening. My journey started in the early 80s and went through to the mid-90s where I ended up in intensive care. Didn't want to talk to anybody about it because it was so strong, the obsessiveness and the self-control I had. I'm healed now, and it went all the way through till the sort of early to mid-2000s. But I'm not sure if anybody spoke about people that don't go for help and don't want to go for help because the obsession is so strong every time they look in the mirror, they just don't want to go for help. That was my main thing. Thank you.
Thank you for your comment.
Did it make sense?
It did. Thank you. We've got some questions. Are there any more questions from the floor? We've got some questions from Twitter. Have we got anyone from?
We got Lily.
We've got loads. I'm sorry.
I'm a member of a charity called Eating Disorder Support, and we run a helpline. And so many people who call us won't go and get proper help because they're frightened of being weighed. Why does a counsellor have to weigh them every time they see them? And they won't go. So many people it happens. Again and again.
Would anyone care to respond?
So I think it links absolutely with the messages around we need to do more at a community level to help people feel that they can go and seek help. Weighing is a really tricky issue. There's a campaign that you might have come across by Hope Virgo, who's another kind of expert by experience about digital scales, which is more around getting rid of weight as a criterion for services, which I think is really important. Absolutely, it goes without saying we shouldn't be deciding who gets treatment just by BMI. I think the issue of being weighed in treatment is a tricky one because sometimes we have to safeguard people medically, and weight is part of that if they're underweight. But we always try to have a conversation with people about it and work with where they were at to come up with something that's going to be acceptable to them as well as facilitate their treatment. For CBT, there is a really strong evidence base that being able to tolerate knowing your weight is important as part of treatment and recovery. But again, we want to have a conversation with people about that. But getting them to us is the first step for us to be able to have those dialogues, which is why we need to do more at a community level.
Can I just add? I think what James has said is key to this, which is, and I don't work with eating disorders. I mean, I do sometimes, but it's primarily if they're homeless. But absolutely key to this, and I think this is true for the whole of mental health, the first port of call is that you have a conversation, that you talk to someone about what they want, you develop a relationship within which you might then say to them, do you think it might make sense that we do weigh you because you look very thin? Now, that's a very different thing to pushing someone onto scales every time they walk through the room. So I think it's really key that it's based on a therapeutic relationship at the start.
We are sadly running out of time. There are quite a lot of questions coming in from Twitter and from elsewhere, but we're not going to have time to do credit to them. I just want to read a couple out because they kind of take us onto topics that we haven't covered so far. One was, how can we ensure that anti-obesity campaigns don't have unintended consequences, such as increasing the risk of disordered eating behaviours? There's one here on what can we do to improve the medical education of doctors across the profession, not just those with specialists. How can we improve eating disorders awareness and training for teachers, parents and anyone willing to listen so that symptom recognition is better early on? So many interesting conversations that we could, if we had time, carry on thinking about together. But I think unfortunately we probably need to wrap up now. Thank you all for being here. Thank you enormously to all of the speakers for your contributions and comments and expertise. And onwards and upwards with campaigning for more investment in research and service development in this area. So thanks to all of you who are already contributing in that area. Thank you very much.
Thank
And
you.
with that,